Hello everybody, EHJ Today. My name is François Mach. Today we are February 13 and I'm the pleasure to discuss some trials, mainly the HOPE-3 trials from last year, New England Journal of Medicine, 3 landmark papers with Professor Salim Yusuf from Hamilton, Canada.
Well, thank you, François.
So, first questions, basic questions, Salim. What are the main message from these 3 HOPE-3 trials?
Well, the HOPE-3 trial tested the concept that lowering blood pressure or lowering cholesterol across the whole range of risk factor level would benefit people or not. As you know, there's epidemiological data to suggest that, but we didn't have clinical trial data to show that. So we took 12,700 people from 28 countries, 229 hospitals, and randomized them to receive blood pressure lowering using low doses of candesartan plus thiazide or statins, rosuvastatin 10 milligrams a day, each compared to their own placebo. But we used what was called a 2x2 factorial design, which meant 1/4 of the patients got both, 1/4 got neither, i.e. double placebo, and 1/4 got rosuvastatin alone, or 1/4 got only blood pressure lowering alone. The trial results were quite interesting. First, the statin worked in everybody. It worked irrespective of the LDL level. It worked irrespective of the risk factor level, irrespective of age, sex, region of the world, Asians, non-Asians. It worked everybody. It was safe. The only side effect was a small excess in muscle pain or muscle weakness, which was reversible on stopping. There was no excess in rhabdomyolysis or myopathy, so it was remarkably safe and remarkably effective at 25% reduction in the primary endpoint of cardiovascular death, myocardial infarction, and stroke and heart failure. With the blood pressure lowering, we had a different result. Overall, it was a neutral result, but we had pre-specified that blood pressure lowering may have a different result in those with elevated blood pressure and those who didn't. So we looked at the people with the highest third of the blood pressure, the highest tertile. The cutoff was 143, which essentially is 140. And in those people, there was a 25% risk reduction with a 6 millimeter reduction in systolic blood pressure. In the people in the middle third, that is 130 to 143, the blood pressure reduction was the same, but there was no benefit. And in those with a lower blood pressure, below about 130 or 131, again the same reduction in blood pressure, but there was a tendency towards harm. So these 3 effects, a 25% benefit, a 0% effect in the middle group, and about a 20% adverse effect, was statistically heterogeneous. And this tells us that we really should confine blood pressure lowering to those with elevated blood pressure. Now, as I told you, we could test the combination arm. And so the combination versus double placebo overall was about a 30% benefit. But if you focus on the people with hypertension, then there was a 40% benefit with the combination. And those who don't have elevated blood pressure, we should just treat them with statins. So it actually gave a useful clinical and public health answer.
So if I'm correct, you need to measure blood pressure.
Yep.
I think it's good.
Yes.
Cheap.
Cheap.
Non-invasive, we will all agree. And for the one, where will you put the cutoff to say statin to all of the above blood pressure millimeter mercury?
I would use statins in everybody irrespective of the blood pressure level. Okay. But the one key thing that has come out of this is in most blood pressure guidelines, they focus on blood pressure. They don't focus on other risk factors. So this is saying that if you add a statin to people with hypertension, you're doubling the benefit, which is an important message. The other part of it is the way we designed it. The drugs were not titrated. There was very little safety monitoring, and yet it was safe. So low doses of combination blood pressure lowering and moderate doses of statins was remarkably safe, easy to give, and effective.
If we speak more globally, I mean, about 10 years ago, there was this concept that each diabetic patient should get a statin.
Yes.
Now we're going to have almost the same for high blood pressure, which is something new. And thank you for this beautiful trial. So do you think this will be endorsed, that all high blood pressure person living on this planet should get, without looking at LDL, a low-dose safety statin?
Well, I hope the guidelines will adopt it. Remember, HOPE-3 is not the first trial showing a benefit with statins in high blood pressure. The ASCOT study showed it, although it was a higher blood pressure level, but the concept is the same. The cholesterol trial is collaboration meta-analysis shows benefit in those with hypertension, those without hypertension. So we now have cohesive data, and the totality of information is very consistent. I already know at least one blood pressure guidelines in which I'm involved in, an international guideline, is incorporating the statin as part of treatment.
Now you mentioned that it's a Polypill. If you compare ASCOT to HOPE-3, where are we with Polypill, meaning placing in one tablet two lowering blood pressure and one statin? So where are we now?
I think the Polypill is an important concept, and it's an important way forward. The Polypill is using 3 blood pressure lowering drugs, a statin, and in secondary prevention, aspirin as well. So far, we've not had a clinical outcome study of the Polypill, and you know it would be unethical to do one in secondary prevention. So we're doing a big study of 5,000 people in higher risk primary prevention with the Polypill versus placebo. We have about 4,400 people randomized. We hope in about 4 months we will randomize 5,000, and then hopefully in about 2 or 3 years we will have results. And unlike the current study where we use low doses, there we're using full doses of 3 blood pressure lowering drugs and a statin, and hopefully the benefit will be about 50% risk reduction. We'll see. And if that is so, it'll improve adherence. The cost will likely go down, and it will be more convenient for physicians. They don't have to write 5 different drugs and titrate them up, and it's convenient for the patients. So the Polypill has potentially a big role, and hopefully that can dramatically improve cardiovascular prevention.
I cannot resist to speak about the money that will be spent, speaking about the new PCSK9 that will come in few weeks with some outcome data. There will be billions on the table for few patients. Where will you, if you were the, let's say, health minister of this planet, where will you place this 1 million or 1 trillion, I don't care, to protect which kind of patient around the world?
I think we had to see the full results of these trials, because a press release with 3 lines does not give you much information. We have to look at how big the effect is. From what we know, there is going to be a benefit. Is it a 50% effect or a 25% effect? That makes a difference. What are the side effects? There is always concern of increased diabetes. There is a concern that very low LDL might increase intracerebral bleeds. We need to know that. And there could be off-target side effects that we don't know. So we need to know the magnitude of benefit, the side effects, and then ultimately cost. But cost is not a constant thing. Things may start off expensive, but the price could come down. But even with that, we're never going to have the PCSK9 at a level that is, say, the cost of statins. So it is possible that there may be a role for the PCSK9 in very high-risk people, not high-risk, but very high-risk people, and the Polypill in most of the people, in most secondary prevention, say 90% of secondary prevention, and in most high-risk primary prevention. The PCSK9 will also likely have a role in familial hypercholesterolemia. But one may ask the question, perhaps, a Polypill might work in familial hypercholesterolemia. Who knows? I don't know. But there are no trials looking at that. So I think the PCSK9 will be niche drugs. their prices will be relatively high early, but over time, as there's competition between the companies and eventually they all become generic, although with biologicals, they tend to keep the price up, it could go down. The other thing is, there was a major trial that was also stopped last week, the COMPASS study, that showed substantial benefit with rivaroxaban. So how many drugs can you give people? So I think the strategy will be tailoring the drug to not only the patient characteristics, but also the affordability. And as a health minister, one has to look at not treating one condition, but treating all the conditions. How far will my budget go? So let's wait for the results. There will be a vigorous debate. We are in for interesting times.
Thank you so much.
Not at all.
For this information. Looking forward for future results.
Well, thank you very much.
Meeting you again here in Davos. Thank you, Salim.
It's been a pleasure, François.
Thank you.
Thank you.